if someone is in asystole and I see atrial systole, systole, what does that mean? Does that mean the P wave is like higher?
It is going to show up on the waves. It's going to show up on the readout. Now, one thing I've never been taught is to read the EKG. I can look at it and I can know what is normal, okay? And if something else comes out that's not in the normal, I just know it's abnormal. So to say that I would be able to tell you if that's the atrial, systole, whatever the case, I can't, okay? I would be dependent on the doctor being able to read that. But I can look at that readout and know if it's normal or abnormal, okay? One time, they left it in the room with me. They decided that wasn't a good idea when they came back in, you know, because I was like, ooh, let me see what I can do here. And I did, and they didn't like it a whole lot. But, you know, so I'm not left, you know, people, like my doctor, she knows better than to leave machines in the room with me. When we look at what happens, the P wave, okay, is going to let that doctor know that the SA node and the atria are involved. The QRS complex is going to let that doctor know it's the ventricles. The ST segment is going to let the doctor know ventricle relaxation. The T wave is, well, contraction, T wave, relaxation, and recovery. So if there's anything wrong in any of those peaks, your hope is that your doctor is going to look at that readout and be able to determine what part of the heart may have an issue. So when we look at the flow of blood through the heart in relationship to the EKG, this is what it looks like. All right? My P wave, dealing with my atria. This is looking at my blood moving into my atria. That correlates to the P wave. From the atria, blood has to go to the ventricles, right? Okay, so if my atria are going to be relaxed, and if they begin to fill, all right, we have to have the blood flow to the ventricles. So my P wave is going to let them know about the atria filling with blood. All right, now when I begin to go into my QR of the peak, okay, my ventricles are depolarizing, meaning they're filling and they're getting ready to contract. They haven't contracted yet, okay? Now, if I go from QR and come down to my S, okay, my ventricles are full of blood. They are at their peak of the depolarization, and they're getting ready to contract. So S to T lets me know about the contraction of those ventricles, and the rest of my T wave lets me know about the ventricles pushing out, basically the emptying of the blood from the ventricles. So every single part of that ECG is telling the doctor something about the the heart beat, one full cycle. Atria filling, ventricles filling, atria emptying, ventricles emptying. And the strength of the contraction. So they are extremely clinically significant. This is normal. When they place the little sticky things in the leads, turn the machine on, and then turn it back off, if the entire sheet that they let roll off comes out looking like this, that is a normal heartbeat. Anything that deviates from any of these peaks and valleys and waves is something wrong with the heart. It helps the doctor know where to start treating the patient. Some things that can make the ECG be abnormal, of course, a heart attack. Anything that's in those pathways, from the SA node to the AV node to the bundle of His to the Purkinje fibers. Heart enlargement, which would deal with a lot of diseases that could happen in the body. But the heart enlargement means that the heart is not pumping, basically the blood is not moving correctly. Electrolyte and hormone imbalances can be detected. The calcium, the sodium, the potassium. Those are the three major players when they look for them.
So can I ask you a quick question? This goes back to a couple slides before. RMP means resting membrane potential.
Because remember, we talked about the firing of the SA node, which is modified cardiac cells, and then we talked about the potential in the actual myocardium, the actual cardiac cells. So when something makes the heart not beat correctly, it's termed an arrhythmia. A without rhythm. The normal rhythm, when you listen to someone's heart, it's usually two sounds. There can be a third sound present, all right? But you know, as you do that out in your clinicals and then into your profession, you're pretty much going to get oriented to what should be the normal sound. Well, if we have something that does not sound right, okay, the two sounds that you'll learn, okay, it could be where those signals, those electrical signals, are not traveling correctly. They might be traveling to the wrong part of the heart. If that happens, we can't pump blood. If we can't pump blood, there is no movement into the coronary vessels. That means no blood flow to the actual tissues of the heart. Well, if we stop blood flow to any tissues of the body, that's an infarction. Note, I said stopping blood flow to any tissues of the body is an infarction. When it happens to the heart, we term it myocardial because it's stopping the blood flow to the actual myocardium, the cardiac cells. if we don't get that heartbeat back under control, yes, it can be deadly. So, ta-da, we sometimes need a defibrillator. Have y'all noticed the ones that we have in the hallways? Okay, and trying to think, why did public places start putting those in everywhere? Was there some kind of law or something?
Yeah.
Or, I don't know. I don't know why public places started putting them
Because they save
everywhere.
lives a lot faster than
I think they just were.
CPR.
Do it, Andrew?
It's just smart.
Just smart.
Just the right.
They're really
thing to
easy.
do.
If the people can operate it right.
No, they're like, no, that's not true. They are like,
Which I
they're
know.
very, they
they're
tell
very-
you, they speak to you,
It
so.
tells you what to do.
Oh, they like when you
Yeah,
open
they
the
talk
little
to you.
thing,
It'll say,
It'll say
it
tap.
starts a little, oh,
I mean,
cool.
that's what's gonna
That's
save.
not-
Not
ours
that I
how it
want to
works.
have it done. Okay,
Yeah, ours
not
don't
that I
work.
want to have it done, but that is kind of cool that they'll walk you
But
through it.
still, when you're shopped and using it, you're not going to think to listen to that.
True.
Okay, so an infarction is stopping blood flow to any tissue. That's like in the body, is what
In
you're
the
saying.
body.
But like when it happens in the heart, it's called
The myocardial,
myocardium.
because it happens to the myocardium.
Okay, myocardia. Okay.
Yeah, the myocardial infarction, which would be stopping the blood flow to those actual cardiac cells. So, defibrillation is that electrical shock that can be given, and the hope is to return it to the normal sinus rhythm. When this arrhythmia occurs and defibrillation takes place, and if we could get it back to a normal beat, okay, it's a acute cure, all right? It's not a chronic cure. Usually that means let's do a little more research and find out why that arrhythmia happened. I mean, that's hopefully what the doctor would do, just saying. When we look at some of the other problems that can happen and can be picked up by an ECG, we have one called heart block. This is one that you might hear like on the shows and stuff like that. And when they say heart block, that conduction system. What's my conduction system? That's my SA node to my AV node to my bundle to my Purkinje fibers. That's my conduction system. The heart block is saying it didn't work. We can have premature ventricular contraction, meaning the ventricles contract before they should. All right, and that can be bad. It can lead to an extra beat in the heart, and that hopefully can be identified from sound. But if not, we can also see it on an ECG.
Yeah.
The sounds, the filling of the blood, the movement, the flow, atria ventricles. I've mentioned this several times. It's based on pressure. Your textbook is going to get into great detail about this. If you were leaving my class to become a cardiologist, I would get into that great detail. But I'm going to try to keep it on a level that is understandable And if you decide to go into that like area of nursing or whatever the case might be, you'll learn as you're trained. Okay? Now, when we look at the heart, all right, my atria, my ventricles. We know that for the most part, materials like to flow from an area of high pressure to low pressure. Is that correct? So my blood that would be returning to my right atrium. Now, that little video that we looked at, remember how I kind of was like getting you to pay attention to those valves and so forth? Okay, so let's say that my blood is moving into my atria. And the valve, my tricuspid, is closed. As the blood flows in the beginning, it is under low pressure, right? But as my blood flows into my atria, what happens to the pressure? My pressure goes up. Is everybody with me? Now, can it just continue to do that? No. That higher pressure is going to make my tricuspid valve open. Okay? But for right now, take a break. Be back at 9:30.